Start. We'll be recording for archiving purposes. So the floor is yours. Thank you, Dr. Rehan, for joining us today. We have you may start, please.
Okay. Thank you very much, Dr. Hisham, and good evening, everybody, whoever's online. Just introduce myself. My name is Rehan Saif. I'm basically a HPB and abdominal multi-organ transplant surgeon. And today's topic is basically a broad overview of liver transplant. I am aware that most of the audience are surgical oncologists, so I'll try and tailor my talk to what would interest you. Basically, for liver, talk a little bit about liver cancer, HPB in particular. So yeah, I'm currently working as a consultant in Burj Al Medical City in the Emirate of Abu Dhabi. I've been here six months, and most of my talk that I'm going to give is from my experience in transplant in the UK and more recently in India. We are in the process of setting up a transplant unit in the current hospital, but we haven't got it off the ground yet, but hopefully soon. So I hope everybody can see my screen. Okay, yeah. So this is where I basically work. I basically work. This is the most recent addition to VPS Healthcare, which is the group that I work for. Burj Al Medical City is a 450-bedded quaternary care center just on the outskirts of Abu Dhabi. Its main focus is oncology. We've already started bone marrow transplant and hopefully we'll be starting solid organ transplant soon. So this is where I work. So I think when we talk about liver transplant, no talk is complete without mentioning these two gentlemen, Sir Tom Starzl on the left and Sir Roy Khan on the right. Tom Starzl is basically considered the father of modern liver transplant. He was the first to perform a liver transplant in 1963 in the US, and Sir Roy Khan in the UK the subsequent year. And liver transplant, as we know it today, is mainly because of the pioneering work of these two gentlemen. So these are the milestones. Sir Tom Starzl attempted the first transplant in 1963 in Denver, Colorado. And after a lot of unsuccessful attempts, it was in 1967 that he had the first 1-year survival. And largely through the 70s, it remained an experimental procedure with the 1-year survival rates in the region of 25%, even with good surgical techniques. So it was not until 1983 when Sir Roy Khan discovered cyclosporin and introduced it into the immunosuppression protocols that the survival rates largely went up. So we all, that's what changed the landscape of liver transplant. And in the 90s, it became widely accepted as a modality of treating patients with end-stage liver disease. And then subsequently, further developments with split liver transplant, where a whole organ is basically split into two and given to two recipients. And then in the early 90s, living donor liver transplant, where a healthy donor donates part of the liver. So these are the milestones. This is basically what happened in India. It was not until 2001 where the first successful disease donor transplant happened, and subsequently living donor liver transplant, which is majority of the transplants in the East and the Far East. Almost 90% of the transplants are live donor liver transplants. Only about 10% are deceased donor. That's largely to do with the development of organ donation, disease donation in the Far East. This is quite the opposite to the West, wherein majority of the transplants are disease donor transplants. So what is the situation in the Arab world? This is information that I've recently, for the purpose of this talk, really, been reading a bit through literature as to what has been happening in this region. So throughout the Middle East, there are only 7 countries that perform transplants, and 2 of the biggest programs are in Saudi Arabia and the other one in Egypt. So it was in 1990 that the first liver transplant actually happened in Riyadh, and in 1994 the first structured program was launched with the Saudi Center for Organ Transplant, which is the authorization committee or the body which is in charge of regulating the procurement of organs, transplantation, and then allocation. So as of today, there are 4 centers in Saudi Arabia, 3 in Riyadh and 1 in Dammam. And they've done more than 2,000 transplants since the initiation of the program in 1994. The first pediatric transplant in 97, and the first living donor liver transplant in 2001. Egypt has largely followed suit. Majority of the transplants, I believe, are living donors because there's no disease donation happening there for various reasons. Currently 13 centers, I believe, and there have been more than 200 transplants that have been performed to date.
One was actually performed by Rehan Saif, one of the usual, he usually attends the webinar, but not today because he's traveling. But Dr. Rehan Saif was the one who performed the first liver transplant in Egypt, so worth mentioning.
Okay. So Saudi Arabia and Egypt are really leading the way for, in the Arab world in terms of liver transplant. Coming to the UAE, as you all know, it's the 2nd largest economy in the Gulf with not a big population, 9.3 million population. Over the years, one of the primary unmet medical needs in the region is the availability of solid organ transplant. So all patients afflicted with end-stage liver disease have had no option but other than to travel abroad for their transplants, and really patients who do not have a suitable live donor have pretty much limited or no options as they do not qualify for allocation of disease donors abroad. The transplant scenario in the UAE is largely regulated by and guided by the Saudi Center for Organ Transplant. More recently, in 2017, the brain death law was passed, and now we do see an increase in the number of disease donations happening. In terms of burden of liver disease in the region, that's a bit difficult to gauge, as there is not much data out there, but chronic liver disease has contributed to, it's one of the top 10 causes of mortality, and the highest prevalence of WHO has actually predicted that this is one of the areas with the highest prevalence of non-alcoholic fatty liver disease, which is the major indication for liver transplant today. And they've predicted by the year 2030, almost 3% of deaths would be related to non-alcoholic fatty liver disease and development of HCC. Just to give you an idea about the wide gap between the need and availability of transplant. This is data from India. Almost 200,000 patients every year die of end-stage liver disease. Almost 25,000 of these could be saved, lives could be saved with the transplant. Only about 1,000 transplants happen every year, and out of these, only about 100 are from disease donors. So that sort of gives you an idea about the wide gap between the need and the availability of transplant. So when we talk about transplant, where do the organs come from? Unfortunately, we do not have a cupboard where you can just go and pick out what organs you need and then transplant into them. The reality is that transplantation needs organ donors. Again, this is the law from India, where basically the concept of brain death as to qualify as death, and then regulations put in place for the mechanism of brain death testing were passed, and this is really the transplant regulatory body that controls the procurement and allocation of organs. I think for any country that would go in this direction, it's very important to have the regulations sorted out, and the UAE has been following suit, and now we do have a similar regulation since 2017 locally for the procurement and allocation of organs. But we still have a long way to go. This is a graph that shows the organ donation rates per million population. As you can see, the country that's leading the way is Spain. It's a small country, but their donation rate per million population is 36. You can compare that to India on the far right. It's 0.3%. And most of the countries don't even figure on that graph. So there's a lot of work that needs to be done, and this is really the responsibility of all healthcare individuals that are involved in transplant, basically to increase awareness, because a lot of organs go waste every day. So as I was saying, there is now a law in the UAE defining brain death as a means of death. The first donation happened in July 2017, a few months after the passing of the law. 2 kidneys were donated that were transplanted locally. The first disease-donor liver transplant happened about 6 months later in February 2018. And the first live donor liver transplant happened in the same year in July 2018. So currently there is only one multi-organ center that does liver and kidney transplants, and 3 other centers that do kidney transplant. Over the last, this is data up until September of last year, there have been about 26 liver transplants performed, 11 disease donor and 14 live donor, basically from this one center. So majority of the people still travel abroad for this treatment. So how do we do evaluation for transplant? So basically there are a few things that we need to consider. We've got to define who are the patients that will benefit most from transplant, and who has the best chance of post-operative recovery and survival through the procedure, and also identify individuals who would value and take care of the precious resource afforded to them. Referral to a transplant center is usually made once liver failure develops, ideally in a timely fashion, so that it gives an opportunity for both the healthcare personnel involved and the patients to understand the whole process and for a thorough assessment, because this is a life-changing procedure, and it requires complete dedication from both patients and their caregivers. One of the challenges we face in patients who develop acute liver failure or fulminant liver failure is the shortage of time from the onset of the disease to the transplant. But really, whenever possible, early referral is what would prevent a lot of issues that you would face post-transplant. Few basic questions to be answered. You've always got to ask yourself, is there an alternative treatment for the liver disease or the liver failure? Will the patient survive the major surgery and the postoperative period? Any major comorbid conditions that would severely limit survival, making this complex task inappropriate? Will the patient comply with the complex medical regimen that is required? Because all these patients need to be on follow-up for the rest of their lives. So that's very important to judge. And in cases where you would transplant for cancer, would the recurrence rate in the transplanted liver be acceptable? So these are the basic questions that you need to answer before considering anyone for liver transplant. The evaluation itself involves intense medical, surgical, psychiatric, and social screening, which is very, very important to identify those patients who may have contraindications. And the regulatory process has to happen once the screening is complete. Generally, a committee comes together to evaluate the whole process and determine if it is appropriate to proceed or not. So when would you consider liver transplant? Whenever any patient who has end-stage organ failure and the procedure would extend the life expectancy beyond what the natural history of the underlying disease would predict, you should consider the procedure. In certain situations, liver transplant is a life-saving operation, unlike a kidney transplant, which is a quality of life operation. But you would also consider it in certain situations where the quality of life would be improved. For example, patients with primary biliary cirrhosis who have intractable itching and really it limits their quality of life. And patients should be selected if the expected survival in the absence of transplant is 1 year or less, or like I was saying, if they have an unacceptable quality of life and the procedure would improve their quality of life. Why should we consider liver transplant? Patients with end-stage liver disease or decompensated liver disease, you can look at the numbers here. Without a transplant, their 1 year survival is usually in the region of 70% or less. A majority of these would not survive beyond 3 years. In comparison, now with the development that has happened over the years in this field, 1 year survival is in the region of 90%, which is better than most cancers, really, and a 5 year survival in excess of 80%. So the important message is that this is no longer an experimental procedure, and it really does give the patients a new lease of life who would not be expected to survive beyond 1 to 3 years. What are the indications? This list is by no means exhaustive. Basically, any patient who has end-stage liver disease or decompensated liver disease with complications should be considered. So as all of you know, chronic liver disease is largely a silent and asymptomatic disease. They don't really develop any symptoms until they decompensate or develop complications such as GI bleeding, when they develop encephalopathy, jaundice, ascites, they develop a HCC or spontaneous bacterial peritonitis or hepatorenal syndrome. So this is really the point where anybody who is any physician who's looking after these patients should really refer them to a transplant center for consideration or evaluation of transplant. This is actually the most important thing, because one of the most important predictors for postoperative mortality is the condition of the patient pre-transplant. So once they develop any of these complications, this is the point that they need to be referred. Generally, you see extremes where patients are in ICU, on the ventilator, with renal failure, severe jaundice and GI bleeding, and that is the point where people would say, is transplant an option? Transplant really isn't an option then. So the earlier they are referred, the better the outcomes. So the first development of complications, that's the point at which they should be referred. And it also gives, very precious time to both the, healthcare personnel and the family to understand the whole process and to come to a informed decision if this is the way they want to proceed. And like I was saying, this is the most important predictor for postoperative survival. You can see what happens if they don't undergo a transplant. The median survival of all cirrhotics is in the region of 9 years. Once they decompensate or they develop complications, the survival drops to 1.6 years. And with SBP, further drops to 9 months. And with hepatorenal syndrome, further drops to 3 months. So the first point of decompensation is when they should be considered for a transplant. So with transplant being accepted as an accepted modality of treatment, there have been various survival predictors that have been validated. The most important of them is the MELD score, which is the modified end-stage liver disease score. This uses 3 objective criteria: your bilirubin level, INR, and creatinine. This really predicts survival. This was originally validated for patients undergoing TIPS, but has subsequently been used for predictability of survival or probability of survival for patients with decompensated cirrhosis. So whenever the MELD score is 15 or above, you should be considering a transplant. So this is the score that is used not only to validate the need for a transplant, but also it is used for managing patients who are on the waiting list for a disease donor. So the higher the MELD score, the higher your mortality risk. So you move up the waiting list depending on your score. So basically, like I was saying, development of complications, that's when patients should be considered for transplant, or if your MELD score is more than 15. In certain situations, like PBC or recurrent cholangitis or hepatopulmonary syndrome, these are also indications for transplant. And as you all know, anybody with chronic liver disease, one of the dreaded complications is HCC, development of HCC. So all these patients should be on a surveillance program with 6 monthly ultrasound scans and alpha-fetoprotein levels. And really, once you develop a HCC, it really depends on 3 factors which would determine if you would go for resection or transplant. I'll just talk about that in a few slides. So when we talk about HCC, you also talk about the background liver. There are 3 factors to consider. One is the stage of the cancer itself, the status of the underlying liver disease, and the functional status of the patient. So in patients with good background liver function, you would always consider a resection. In patients who have decompensated cirrhosis in the background with portal hypertension, transplant is the only option. Now, how would you consider which patients are qualifying for transplant? Somebody who has HCC with decompensated cirrhosis. Like I was saying, that really the idea is that the outcomes for transplant after HCC should match outcomes for non-HCC transplants. So there are certain criteria that you would use. These are not set in stone, but especially in programs that are primarily disease donor programs. Milan criteria is the sort of benchmark. This was seminal work done by Mazzaferro and colleagues in Italy. You can see the criteria on the screen there. More recently, we've moved towards the UCSF criteria, which are a bit more inclusive. These are primarily for disease donor transplants. The situation is slightly different for live donor because it's the organ is specific to that particular patient. It's usually a near relative. And as long and generally the metro ticket calculator is used for that, wherein it's an algorithm wherein you put in details about the cancer, and as long as you can get more than 50% 5-year survival, a transplant would be justified. That's in the living donor scenario. So the world is rapidly changing with urbanization and increasing, lifestyle changes, sedentary lifestyle, increase of alcohol and tobacco, with the metabolic syndrome, obesity. Like I was saying, this is the most common indication for transplant everywhere in the world now, more so in this part of the world. You can see that the WHO prediction, especially for the Middle East, is 150% by 2030. And certainly in my practice over the last 5 years, when I speak to people who are non-medical, everybody thinks that transplant is basically for alcoholics. But in fact, alcohol-related cirrhosis forms only about 30% of the transplant practice. The most common indication for transplant these days is non-alcoholic fatty liver disease, especially HCC. So what are the contraindications for transplant? Broadly speaking, conditions that either render the surgical risk prohibitive or the likelihood of long-term survival is low, then we should think carefully. These generally tend to be dynamic and different between centers, especially in the setting of transplant for HCC, depending on the local expertise and level of comfort. But there are certain absolute contraindications: AIDS-related illness, any anatomic abnormality that precludes transplant, severe cardiopulmonary disease, presence of extrahepatic malignant disease, and the social setting also needs to be evaluated. If the patients do not demonstrate understanding that they have to be compliant with their post-transplant medication lifelong, you would generally not transplant them, because this is a precious resource, and also in patients with uncontrolled sepsis. Relative contraindications, like I was saying, that vary from center to center and sometimes are modifiable. We generally talk about advanced age. It's the most common relative contraindication, although as with everything in medicine, chronological age, it's generally a good framework to operate from, but physiological age is more important. But most programs would not transplant for patients beyond 70 years of age, except under exceptional circumstances. Obesity is the other issue. Again, this is a relative thing. We do know that the mortality is much higher in patients who are morbidly obese. The most centers would again turn down patients more than a BMI of 40, but we have transplanted, I think the biggest patient that we've transplanted was a BMI of 43. So it depends on center to center, but we do know that the mortality is higher in somebody who's morbidly obese. So we'll just take a lateral detour. I just put this in because I was aware that majority of the audience are surgical oncologists. So just talk a little bit about HCC. We do know that majority of HCCs are in cirrhotic livers. I'm not going to talk about non-cirrhotic HCCs because resection is the way in them. So what are the challenges in patients with HCC on a background of cirrhosis? We do know that the only two options for cure are either resection or transplant. Ideally, transplant has the benefit that you're not only treating the cancer, but you're also treating the background liver disease, but we do not have the luxury of enough organs for everybody. So there are certain things to consider to tailor your management. We'll talk a bit about how to assess the liver and the degree of portal hypertension, how you would select candidates, what are the surgical aspects we need to consider, and also about salvage transplant. So what are the advantages of resection? It of course gives you pathological information, because we do know in patients that we transplant for HCC who have microscopic vascular invasion, which you only find out on histopathology once the liver is out. Then we know that these patients are at very high risk of recurrence. So resection offers the advantage of pathological information. They do not have to wait for an organ if they are going for a diseased donor transplant. And of course, in the setting of live donor transplant, no healthy live donor has to undergo a liver resection. There is, of course, no immunosuppression that the patients need to be on lifelong. And also for patients who have tumors that fall outside the criteria that we've spoken about, resection is an option. And with all these patients, transplant always remains an option later on. So these are the advantages. What are the disadvantages? We do know that resecting HCC from somebody who's got a cirrhotic liver, there's always a high recurrence rate, more than 50% in the remnant. We always worry about major resections in somebody with cirrhosis, because the risk of postoperative liver failure is high. And also the other disadvantages, you might be missing smaller HCCs that are not visible on imaging. How do we assess these patients for portal hypertension? Of course, anybody with, we all are aware of the Child-Pugh score. Patients who have good or early cirrhosis with a child A status, of course, should always be considered for a resection. I spoke about the MELD score earlier. Score more than 10 predicts the risk of postoperative liver failure in 15%. So ideally, your MELD score should be below that. Certain non-invasive ways to assess the degree of portal hypertension: if the platelet count is less than 100,000, patient has splenomegaly on imaging, and all these patients should have an upper GI endoscopy, and any presence of varices should preclude a resection in these patients. The other thing that we can do is assess the remnant liver with volumetry. We all know that the future liver remnant should be at least 30% in normal healthy liver. In anybody with CLD, at least 40%. In somebody with cirrhosis, at least 50%. And the hepatic venous pressure gradient is more of an invasive tool. So this is really the pressure difference between the pressure at the wedge pressure of the hepatic vein and the free hepatic vein pressure. And anything more than 10 means that they have significant portal hypertension. And this is one of the important predictors for postoperative liver failure. Of course, we should exclude metastatic disease. And like I was saying before, stage the liver disease and the tumor both, functional status of the patient, and exclude extrahepatic disease. So this is generally, this is actually from one of my bosses who trained me. He always used to say this. So one way to look at it is to look at the tumor and the liver. So if you've got a combination of good liver and good tumor, resection is the way to go. Good liver with bad tumor, there's always the option of downstaging the disease and then resect. If it's a bad liver but a good tumor, of course, transplant is an option. The other option is to increase the future liver remnant with some liver-directed therapies. And if you have bad liver and bad tumor, then the only option is either a transplant if they're in criteria, or palliative supportive care. How can we increase resectability rates? Transarterial chemoembolization and more recently radioembolization. This has the advantage of not only treating the tumor, but also increasing the future liver remnant. Like I was saying before, in cirrhotics, we should aim for at least, if you're considering a major resection, at least 40 to 50% of future liver remnant is desirable. to decrease the risk of postoperative liver failure. In patients who have vascular involvement, vascular reconstruction could be done. And the more extreme situations, what we can consider as an ex situ liver resection, where you actually remove the liver, resect the tumor, and then put it back. So these are sort of extreme situations. This is just an example of a cirrhotic liver who underwent right hepatectomy. That's the tumor. You can see the quality of the liver, and that's the remnant left lobe. So these are actually quite challenging because of the quality of the liver parenchyma. Some of the things, this is again another situation where transplant wasn't an option because this was outside criteria. So for a multifocal HCC, combined resection and ablation is another thing that you can do. When we're operating on cirrhotic livers, a few things, always try and minimize the blood loss, because we know that this is detrimental. It has to be as smooth a procedure as we possibly can. Large tumors, we can use the anterior approach, and TACE and TARE are always in your armamentarium to try and treat these tumors. And whenever we are treating HCC on a background of hepatitis, all these patients need to be on antiviral therapy pre-op. This has shown to reduce recurrence in the remnant liver. Salvage transplantation. So what's the logic of this? So patients initially can have a resection who can have resectable disease. For a subset, might avoid transplant. And we can always transplant the patient if the patient develops either postoperative liver failure or recurrence in the future. How do we prolong survival after recurrence? We can go back and resect these tumors again. More than 50% 5-year survival shown in some cases. Salvage transplantation, like I was saying, is always an option, but there are certain prerequisites. There should be no vascular invasion, it should be a low-grade tumor and no satellite nodules on histopathology, because this would increase the risk of recurrence in the transplanted liver. And if there is any, if there is recurrence, you could always use a combination of TACE, TARE, ablation, or combination of TACE and ablation. So for HCC, generally, there are a lot of options that we can use. So if you can resect, we should resect them, and salvage transplantation is always going to be an option, especially in patients who fall outside criteria and who don't have the access to organs. So coming back to our mainstream topic of transplant. So what essentially happens during a transplant? The diseased liver is removed completely, and then the healthy donated liver is transplanted. The two main types are diseased donor and living donor. Diseased donor, again, can be either a whole organ transplant, or it could be a split transplant wherein it's a full right and left split and given to two adults, or more commonly, a left lateral segment is given to a pediatric patient, and the right lobe is given to an adult. And in neonates, we also have reduced or hyper-reduced grafts, which are segmental grafts. These are in really low weight neonates. In terms of when we talk about living donor, it's always a segmental graft. Generally, a majority of the times, it's the right lobe because of the volume of liver that is required. Right lobe for adults and left lateral lobe for pediatric patients. More when you can, we should always try and use the left lobe because this decreases the risk in the donor, but that really depends on the weight of the recipient. So just some pictorial depictions of what a whole liver or a split liver transplant looks like. In terms of living donor, like I was saying, majority of the times, adult to adult is the right lobe. It's usually a modified right lobe, wherein we only take the right lobe, but don't take the middle hepatic vein. This means that you would have to reconstruct the segment 5 and 8 venous outflow. The reason for this is that it increases the risk to the donor if you take the middle hepatic vein. So generally, it's a modified right lobe graft that is most commonly used, and the venous outflow from segment 5 and 8 is reconstructed either with a vein graft or a synthetic graft. So who can donate? Talking about diseased donors, generally anybody who's brain dead can donate. There is no age limit. There should be obviously no malignancies, no infections. Malignancies except some low-grade CNS tumors. That's not a contraindication. And of course, certain individuals would have signed up or expressed their wish to donate after their life, or in the absence of that, the next of kin can voluntarily express their wish to donate. For living donors, ABO compatible blood group, we also can do incompatible blood group, but that increases the risk of biliary complications. But when we don't have a choice, we can consider that. Generally, between the ages of 18 to 50, they should not be obese. In most countries, there should be a near relative. In India and in the West, it's generally up to the second degree relatives. In the UAE, the local law permits donation for up to fourth degree relatives. They should, of course, be in good health and physical condition and with no major comorbidities. The most important factor that would determine if they're suitable or not would be their intrahepatic anatomy and the volume of liver that is required both for the recipient and for the donor. In the donor, generally, we need to have at least 30% remnant, and for the recipient, it should be a graft to recipient weight ratio. Generally, you should aim for about 1, but greater than 0.8 is acceptable. Of course, all this is done using there's very good software now with CTs and MRs that can determine the quality of the liver and the intrahepatic anatomy. All of these patients would have a preoperative MRCP, and liver biopsy is only performed if the grafts are borderline. It's not done as routine in most centers. So these are some of the, this is just an example. There are multiple softwares now that gives us very good images of the intrahepatic vascular and biliary anatomy. Just skip that. More recently, this is a new development. 3D printing of livers is being used for haptic planning for the donors. So you can see here, this is a silicone 3D print of the donor liver that helps you in preoperative planning and also guides you during the donor operation. All this is done basically to try and minimize the risk to the donor, because as you all know, right hepatectomy is not a small undertaking, and all these newer techniques are generally being developed to increase donor safety. So this is what happens during an explant. So basically the cirrhotic liver is completely freed up, leaving the IVC in situ. So then the hilum is dissected, the hepatic artery, portal vein and bile duct transected close to the hilum, and then the liver explanted. Then if it's a diseased donor graft, which is a full graft, that's retrieved from a brain dead donor, which is then implanted. So basically you do the caval anastomosis. Most commonly, it's a cava-to-cava anastomosis. Some centers would use the piggyback technique where the three hepatic veins, the opening of the three hepatic veins is used for the anastomosis, but the side-to-side caval anastomosis is the most common. Next is the portal vein, which is the end-to-end reconstruction, and the hepatic artery with the celiac artery patch. So this is what happens in diseased donor implant. And the bile duct, of course, end-to-end. In terms of pediatric transplant, is generally, depending on the indication, it's usually a hepaticojejunostomy. In terms of live donor graft harvest, it's the right lobe, like I was saying. We always do cholangiograms, although you would have an idea about what the biliary anatomy is like, but we would still do about 3 cholangiograms intra-op at various stages to identify, because one of the Achilles heel of live donor liver transplant is biliary complications post-op. So this is just a right lobe graft. Like I was saying, this is on the right-hand top corner. You can see a iliac vein graft being used to reconstruct the venous outflow of the anterior sector, that is segment 5 and 8. And on the right lower picture, you can see a synthetic graft being used to reconstruct the venous outflow. And then after everything, all the vascular anastomosis is done, we always do an intraoperative Doppler to make sure that all the joints are okay. And I alluded to this earlier. This is data from the UNOS database, which has well over, I think it's more than 1 million transplants done over the years. So you can see the survival rates on the right there. 1-year survival in the region of 90% and above, and 3-year survival in excess of 80%. This data is actually quite old. The survival rates are much higher than that now. So just a few transplants that I have been involved with. This was a young girl with acute Wilson's disease, so fulminant hepatic failure. This is her 6 months post-transplant. This young child, this is actually the smallest child that I've been involved with. She was 11 months at the time of a transplant for biliary atresia. She stayed about 6 weeks in hospital. This is her 2 years after transplant. This girl here was transplanted for a hepatoblastoma. And this young lady here had acute liver failure because of seronegative hepatitis. And this is her celebrating her first anniversary post-transplant. So it's actually quite satisfying to when you see their lives transformed. Of course, there's a number of people involved, and it's not a small undertaking. The diseased donor status of diseased donor transplant, unfortunately, in our part of the world, it only forms less than 10%. We have brain dead patients in every ICU. So there has to be a lot of work that needs to be done to increase awareness. A lot of these organs can transform lives of lots of people who are on the brink of death. There are very few brain dead declarations, and there need to be regulations in every country, really, because these can save lives of multiple people. So obviously, I'm a big proponent of diseased donor transplant as opposed to live donor transplant, because no healthy person is put at risk. So this is one of the biggest advantages. There's more involvement of the community in the system. And it also largely eliminates the whole issue of organ trafficking. Basically, if every brain dead patient can be counseled for organ donation, we would largely eliminate the need for live donor transplant. It's different to kidney transplant because the risks are completely different. But liver donation is not something that we should take lightly, and if we can avoid it, we should. So this is probably the most important slide of my talk. Like I was saying, there's a large team involved, multiple specialities, your other healthcare personnel, your social worker and clinical psychologist forms a very important part of your team. And of course, you need coordination and involvement of most of your colleagues wherever you work for this for your transplant program to be a success. So it really needs integration and teamwork, as with most complex work. So I'll just skip that. So just to summarize, liver transplantation is rapidly evolving. It is now well-accepted modality of treatment, no longer should be treated as an experimental procedure. Unfortunately, most patients are referred late when there is actually a window for transplant. And it's very important for people to realize that early referral is the most important factor that would improve your results. There are very few disease donor programs. Of course, when you talk about disease donation, it's offered the advantages of multiple organs for patients with other organ failure. And there should be a national allocation framework in every country. And with patients who don't have access to disease donors, near relatives are the only realistic chance for their new lease at life. Thank you.
Thank you, Dr. Rehan, for this informative presentation. We can start now by taking questions from the audience. If you have a question, please raise your hand. I personally have a question. So you still didn't perform any liver transplants in the UAE, right? But it's
in the UAE?
Yes.
Yeah, so we have actually, like I was saying, it's only been 6 months. It's a new hospital. We've actually applied for our, we should be getting our kidney transplant license in the next couple of weeks. And actually the management is pushing me to start liver transplant, but I have told them that we need to be a mature program first. Liver transplant is a completely different undertaking to kidney transplant. So I've told them at least 6 months of kidney transplants, and then we can consider liver transplant. So hopefully this year, by the end of the year, we should have a liver transplant program going here. Currently, there is only one other center in the UAE. It will benefit the local population who now have no option but to travel abroad for this treatment.
Okay, great. Any questions from the audience? Dr. Rehan Saif.
Yes, I need to thank you about the lecture. I need to ask about if you encounter in patient with HCC and if you encounter portohepatic lymph nodes. We commonly encounter this here, patient with resectable tumor and portohepatic lymph node like 2 centimeter to 3 centimeter, which is suspicious. How do you exclude if this is a malignant lymph node or just enlarged one?
I'm sorry, you were not very, I couldn't hear your question very clearly. You're talking about decision between resection or transplant for somebody with HCC.
Yes, this patient, but if you have portohepatic lymph nodes in the patient with HCC.
Yeah, so this is a tricky situation. I think generally, again, different centers would adopt different approaches towards this. If in somebody who has extrahepatic disease, you would certainly not consider them for transplant. I mean, you would not consider somebody for transplant anyway in somebody who's got a resectable tumor with no portal hypertension. But if you do have portal hypertension, one of the things that we have used more recently is various prognostic tools. For example, your AFP level. Some centers, including ours, we would not transplant anybody with the AFP more than 400. or the other modality that we would use is a PET scan. Not all HCCs are FDG avid. If you do a PET scan and if the tumor lights up, generally that means that this is a poorly differentiated tumor, and it would be one of the bad prognostic markers. The other thing that you would do is you could subject them to some form of liver-directed therapy, which would be generally be a TACE, and monitor them for the next 3 months. See, once you taste them, and does the AFP level drop? What happens to the lymph nodes? I mean, there's no easy answer to this, but if you're suspicious of any disease outside the liver, we wouldn't be transplanting them in a hurry.
Okay, thank you.
Dr. Suleiman Ashraf.
Hello.
Yes, we can hear you. Go ahead, please.
Thank you very much for your kind lecture. I just would like to ask about a friend of me who's 60 years old, extended discovered with multiple focal lesions of liver, innumerable focal lesions of liver, and there was a sigmoid tumor, not obstructed, no bleeding, no constipation. He started chemotherapy and target therapy, and still his liver function is good. And there is no any tumor outside the liver and sigmoid. Is there any hope for him, or who will benefit from transplant?
Again, this is a very common scenario that you would encounter. Like I was telling, the various prognostic tools that you would use to predict the risk of recurrence in the transplanted liver. Generally, if you have multifocal disease, that would be outside criteria for most of the criteria that we use, either the Milan or the UCSF or the up to 7 criteria. So it would fall outside those criteria. But in the situation of, so they would really not qualify for a disease donor transplant, because they will never get access to an organ because the risk of recurrence is going to be high. But there are some centers that would consider a live donor liver transplant. So there is this calculator that I was talking about, which is the Metro Ticket calculator, wherein you would put in all the details of the number of tumors and various parameters of your liver function. And that would tell you the predicted 5-year survival. And if it's more than 50%, you would consider them. Basically, what you're trying to do is to filter out patients who, because please remember, all these patients are going to be on immunosuppression after their transplant. So you don't want to be in a situation where they've undergone a major procedure and within 3 months you have recurrence. In most situations and in most centers would not qualify for a transplant, but in certain situations, live donor transplant can be considered, especially if you've tested the natural, the biology of the disease by giving some liver-directed treatment, and then see what happens, whether there's a drop in the tumor marker level, have the lesions regressed in size. And so these are, there isn't an easy answer to that. So you will have to, there are various factors that you would have to consider. But I would say generally, no, but in certain situations, yes.
Okay, if you kindly just leave the address of 1 or 2 centers who we can consult for this case for Hisham, and Hisham will forward to me. I will be grateful. This
Sure,
one.
no
Second
problem.
question. Now, this regarding this friend, the PET-CT didn't show any evidence of tumor outside liver or sigmoid, and both of them are resectable or could be resected. Any other modality candidate for possible recurrence, as you said, or possible hidden metastasis apart from PET-CT?
I mean, a PET-CT is not actually used for, and is usually not part of your staging protocol for HCC. Generally, you would stage them with a CT, MRI, and a bone scan.
This patient is colorectal mets, is not HCC.
Okay, sorry, I misunderstood that. And in the setting of colorectal metastases, generally, transplant would not be an option. I mean, there are few Scandinavian centers that are, it's only part of, experimental trials and very, very carefully selected patients for non-HCC cancers. For colorectal metastases, I mean, in carefully selected patients, yes, that would be an option, but in very, very few centers and really part of ongoing trials, most centers would not transplant for colorectal mets. But in terms of staging for metastatic disease, PET scan is probably the modality that you would do. I'm not aware of any other modality.
So again, if you kindly leave one of these centers,
Yes, okay, we will.
address to Sam,
Okay,
and
thank
he will.
you. Dr. Walid?
Hello.
Yes, Dr. Walid, please go ahead.
I would like to thank you a lot for your wonderful presentation. As you mentioned before, if we have a good liver and a bad tumor, you would go for downstaging and resection. So let's say you have a patient who's Child's A and he have portal vein thrombosis, HCC with portal vein thrombosis. You'd still go for downstaging.
Yeah, so it depends if the portal vein thrombosis is tumor thrombus, because if it's tumor thrombus, that would exclude them for transplant anyway, because with vascular invasion, the risk of recurrence is too high. So you would not consider, that would be a contraindication for transplant.
Okay.
So what you can consider for these patients is downstage them and then resect with vascular reconstruction.
Okay, how would you downstage this patient? What are the downstaging options? Neoadjuvant chemotherapy or what?
No, just liver-directed therapy. Depends on the size of the tumor. If it's a small tumor, you could taste them. If it's more than 3 centimeters, you get better results with radioembolization. But then if it is transarterial radioembolization.
Yes, with yttrium.
Yttrium, yeah.
Okay, but if we have a main portal vein thrombosis, would they still be a candidate for transarterial chemoembolization? I think it would not be suitable for them.
Yeah, no, if you have portal vein thrombosis, then you cannot taste them, but you can use radioembolization.
Yes, okay. So radioembolization or just here, right?
Sorry, please say that again.
Either a radioembolization with yttrium 90 or either best supportive care for these patients, right?
That's correct, yeah.
Radio frequency ablation. Okay, do we have any other questions? I think that was it. So, do you have any questions to us? Have you ever been to Egypt?
I have been, but that was on a holiday to Sharm el-Sheikh when I was in the UK. But I would quite like to visit Cairo once.
Okay.
Hopefully soon.
Yes, hopefully soon. We would definitely like to have you with. Okay, thank you, Dr. Rehan.
Thank you very much for the opportunity, Dr. Hisham. Thank
and
you.
hope we can collaborate more in the future. Thank you.
Sure, inshallah.
Everybody have a good
Thank
night.
you. Okay, bye-bye.
Thank you. Bye-bye.